آله وصحبه أجمعين. Welcome everyone to the second installment of this webinar series on post-mortem imaging or virtual autopsy. A topic that is gaining recent traction in the recent few months, I would say, from all medical societies. I am your host. My name is Rayan Ahyad. I'm a pediatric radiologist and assistant professor at King Abdulaziz University at Jeddah. I'm also a board member and representative of the Radiological Society of Saudi Arabia. My co-host, Dr. Abdulaziz bin Shalhoub. So Dr. Abdulaziz is a consultant forensic medicine. He's a medical review officer and SME at Forensic Medical Service Center at MOH. Additionally, he's also proficient in corporate governance and has worked on projects that provide framework for managing organizations. He is a member of the Saudi Society of Forensic Medicine. Before I give the mic to Dr. Abdulaziz to present our esteemed speakers, I want to remind everyone that the Q&A section is available for you to ask a question or leave your questions at the application. And we will address your questions, inshallah, at the end of the sessions after the two lectures. You have the mic, Dr. Abdulaziz.
Thank you so much, Dr. Rayan. I mean, pediatric radiology is something else. It's wonderful, and I'm so glad to know you. I've only been to know Dr. Rayan for days, but it feels like centuries. Thank you so much, Dr. Rayan, for this wonderful, entertaining beginning. And also, it is my great pleasure to welcome you all to our second webinar. I am truly honored to be hosting today's session alongside to our distinguished guests, Professor Michael Thali and Mr. Dominic Gascho from the University of Zurich. Well, for those who didn't enter the first webinar, Professor Michael Thali is an internationally recognized for his pioneering work in postmortem imaging and is a co-founder of the Virtopsy project, integrating technologies such as CT, MRI, 3D scanning in forensic investigations. Mr. Gasco is a research scientist who focus on advanced forensic imaging, including CT, MRI, and MR spectroscopy and spectral imaging. I would also like to extend my sincere gratitude to the Saudi Society of Forensic Medicine, which representative is Dr. Faisal Zbeidi, for this wonderful invitation, and also to the Radiology Society of Saudi Arabia for their support and collaboration in making this webinar possible, which is a very interesting webinar, and they asked for it actually. A lot of radiologists and forensic physicians asked for it. We are delighted to have such a diverse actually audience joining us today from different locations, different specialties. Thank you all for being here with us. Without further ado, it is my pleasure to invite Professor Michael Thali and our guest, Mr. Gasco, to begin today's session. Please, the mic is yours, Professor Thali.
So thank you very much for the invitation. Welcome to the part 2 of our online session, and we hope that we will see us in person in the near future. So the first presentation will be given by Dominic Gascho. You already mentioned it. He's working with our team since many years, and when you go to PubMed and other scientific websites, he's very famous, always publishing cutting edge technology. And so it's really a pleasure that he will start the session demonstrating you what are the basics of scanning, what is necessary, and so on. And after his session, I will give you a short overview what are the normal findings in postmortem CT scanning. Our problem today is a little bit we have to leave the session at 2 o'clock here in Switzerland. That's 3 o'clock in your time area, because then we have another research meeting with another group. Okay, so I'm happy that Dominic will start with the first presentation, and thank you very much again for the invitation.
Thank you for the nice introduction. I will share my screen. Can you give me feedback if you see my screen?
It's clear, doctor. Yes, PMCT scanning.
All right. Just give me a second. Okay. We will start with a brief historical introduction to CT scanning. You are probably familiar with these images on the left. Wilhelm Conrad Röntgen, who discovered the X-rays with the famous image of the hand of his wife. And it's already impressive, illustrated on that early radiograph, the ring on the hand of his wife. So these X-rays are very good to detect metallic objects outside of the body or also inside of the body, as we will see later. On the right image, there's the first presentation of this X-ray imaging or radiographs at the Congress in Germany, where there was also demonstrated how you can visualize the skeletal structures, the bones of your hand. And these all happened at the end of the 19th century, and just a few weeks later, it was also used for a forensic purpose. As you can see on the right image, it's one of the first images where a radiograph was used later on also as evidence in court, and this is nicely illustrated in Brockton's Forensic Radiology. I really recommend to take a look at this book where you have a beautiful historical description, and you will read how early these imaging techniques also were part of forensic investigations. Later on, X-rays were used for other things as well. Of course, today, not anymore for seeing how good a shoe fits your foot, because later on we noticed that these X-rays are not so healthy. And so also today we have these devices to detect the radiation when we perform scanning, CT scanning, or doing radiographs. And that is the same in our institute, where we have these dosimeters to detect any radiation that gets to the body, to be sure that we are well protected, because our CT is inside a room where there's lead in the walls, so none of the X-rays will go through it. But this is just to check for that. But I think usually I will describe at this point of the presentation a little bit about the X-rays, how they are generated. But I think your audience is full of radiologists, so I can skip this part and go right into the image quality and how we can improve the image quality for postmortem CT scanning. There are some parameters you may have to change, that you can get the best out of your post-mortem CT scan. It goes a little bit in another direction than you would use for patients, but we will see that on the next slides. First of all, it's all about in imaging about the contrast in the image. This is the contrast you want to have, more the soft tissue contrast or more contrast between bones and soft tissue. It's also a part of an image is always the resolution. How good is your resolution? And with the resolution, you also have the drawback with higher resolution. You will have more noise in your image. And at the end, the signal to noise ratio is an important part of your image. And then additionally, there are artifacts, but we will not dive deep into the different artifacts in CT scanning, because you're probably familiar with that from clinical radiology as well. At our institute, we have a CT scanner, a Siemens CT scanner with two X-ray tubes inside for dual energy scanning. We have this system since 2010. It will be changed in the next years. We will see what we get, but with that system, we were very happy over the years. We could do a lot of studies, and it was also very good for our daily practice. It is a standard fan beam CT scan with the different kilovoltage settings of 80, 100, 120, and 140. We will talk about this a little bit, where we use which of these parameters to get the image we wanted to have. First of all, we will talk about the tube voltage. We usually use in our department the standard 120 kV because it gives you a very good visualization of the soft tissue and of the bones. If you just have skeletal remains, you may use 140 kV where you have less contrast in your image, but you more happy to visualize the bones inside the image. So we do want to prefer to have a very high kV setting. But for other things, for example, PMCTA here stands for postmortem CT angiography. There you would use 100 kV because then you have a better contrast between your contrast media mixture and the soft tissue and the bones. We will see later on it enhances the iodine contrast in the contrast media mixture. And 80 kV, it's usually for low dose scanning. We do not use it very often, just for maybe for material differentiation, but with 80 kV, we have a lot of noise also in the image. This is what you also see here on the small images, that the noise increases, that the noise decreases with an increase in the kV setting, but also the contrast in the image decreases. As I told you, we work with a dual energy scanner where we have two tubes. We have a benefit with the B tube in that case, with the smaller detector, that we can perform very high resolution scans with a slice thickness of 0.4 millimeters, and the larger standard detector with where we can achieve a slice thickness of 0.6 millimeter for all the basic scans we do. We use a standard energy integrating CT scanner. You probably heard from the new technique, photon counting CT, but we do not have one of these yet. We use the standard CT scanners. They work quite good and did it over the last decades. It's just there, the X-rays that gets into your detector are converted into light, into visible light, and then you have the digital readout of the signal, as you saw on the right on this short video. This is an element of the detector which we put inside the CT scan while we perform the CT scan, and you can really see here how the light is generated when the X-rays hit this detector element. It was here positioned at an angle of 37 degrees. This is such a detector element inside your CT scanner, and just at that small part it happens. I hope you can see the arrow in the presentation here on the top. Underneath these anti-scatter plates, there is the detector element where everything happens. So, as I said before, important thing is the signal to noise ratio. We want really to decrease in postmortem imaging, and we have the advantage to decrease because we do not have to care about patient dose, about radiation dose to the patient. We can use really high dose imaging to decrease the noise in our images. Like you can see here in this graph, there the signal to noise ratio is calculated and illustrated. As you can see, it's almost a linear increase of the signal to noise ratio when you increase your tube current it's the lower line here. Actually, it's not the tube current, but the tube current time product when you perform Siemens CT scans. So, but that's not important here. Just you really increase your signal to noise ratio. You really decrease your noise when you perform high dose scans, and you can do that post-mortem, and that is definitely one of the major advantages. As you can see here again, this is a segment of a head scan where you can really see how the noise reduces when you increase your tube current. So these are the two important things when you perform a CT scan, how you change your tube voltage, or at the end you use the 120 for your basic scans, and the benefit of increasing the tube current. Of course, with time, your X-ray source will have to be changed if you perform too much of these high resolution scans, depending on the department you're working at. Here at our institute, we have around 700 post-mortem scans a year, and the change of our X-ray tube is not much more often than it is in a clinical radiology hospital where they have 20 patients a day. But of course, if you have a department with much more bodies you have to scan every day, then you may not be able to use that high tube current levels, because there's also a cooling phase. Then you may have to wait between your scans. So you have to adapt this on the possibilities you have, or on the amount of scans you have to do. Yeah, I already told you that you can neglect the radiation exposure to the body, and also the absence of movement artifacts like breathing and heartbeat is a major advantage in postmortem CT scanning. What you also want to do is to reduce your scan speed. For clinical images, you often use fast CT scans that you reduce motion artifacts. And in post-mortem images, we want to perform a slow scan that we also can increase the dose. As you can see here in milligray, your dose level will increase if you reduce your, or in this case, if you use a higher rotation time. If your scan takes longer, that has an advantage also for your post-mortem scan. And of course, the pitch, that's the other thing, the table movement during the rotation of the X-ray tube in the gantry. You want to reduce this pitch, that you have overlapped spiral scanning, and that you really have a lot of time to put the high dose on your body, and with that get your images with less noise and good quality. So this is just an overview of the parameters we adapt for our CT scans, for our postmortem CT scans. We have these MAS values where we use high MAS values. We have our kV setting, usually at 120 kV. And then also the other parameters like a low pitch and rotation time. It depends if we use 1 second or 0.5 second. For the entire body, we may use 0.5 second, and just for a separate scan like the head, we may use 1 second. But these are just the scan parameters. After you have performed the scan, you also have a lot of reconstruction parameters that are interesting for you when you do postmortem CT scanning. But first of all, we take a look at how we perform our CT scans, or how we position the body on our CT table. We usually have them in a body bag. If they are quite fresh, deceased bodies with not major injuries, so that they do not that there's not a lot of liquid around as well, or blood because of injuries, then we also use a plastic foil just under the body in order to avoid contamination of the CT table. The body is usually in supine position, and when it is possible, when it is possible due to rigor mortis or to the injuries, we also would align the head that the nose is in a medium position that we can perform, especially for the reconstructions of the neck. It would be advantage to position the body like this. And of course, positioning the body is not always possible in postmortem forensic imaging, like you in these illustrations when you have a train fatality with a lot of body parts inside your body bag. Charred bodies where you're not able to reposition them. We until now we did not really had a problem with the diameter of our gantry, of our CT gantry. It's 80 centimeters. All of the bodies we were able to scan, but especially with these charred bodies, it can be you have to position it quite good on the table that everything gets through your gantry. And also if you have a decomposed body that is very bloated, you may also have to position it in a good position on your CT table that it fits through the gantry. But it worked for all the bodies we had so far in our institute. Like here's an illustration of such a bloated body. It's illustrated with this dark green compared to a standard CT scan. The drawback you have, it's very bloated. For example, the spine, like here illustrated in a spine phantom, if it's on the edge of your actual scan field of view, then you also lose quality in your image. You have more noise the farther you are away from your ISO center, from the middle point of the gantry. So that is also something you may have to keep in mind if you really want to do high resolution imaging. From time to time, we also have bodies that are quite heavy, like in this case with 260 kilogram. Our table, I think it was the limit is 280 kilogram, but because we're performing a scan of the entire body, the table plate is moved almost through the entirely through the gantry, and so we didn't want to risk that there is any damage of the table. And in that case, we used a CT scanner from the animal hospital with a CT on rails on the floor. They use it also for horses, where they put the horse on a table that is able to that you can put bodies on it with much more weight, and just the CT scanning itself is moving during the scan and not the table. It was possible to use this equipment also for this scan, and here you can see the results. We had to do 2 scans. We had to rotate the body on the table for the lower region of the body because the system was not able to scan over a range of 2 meters as we usually do with our CT scanner. But nevertheless, it was possible to create also these images of the inside of the body where you can even see a rib fracture, of course, with more artifacts than with the usually body because of the volume. But X-rays are quite powerful. We tried things out, what we can visualize. On the left, you see a skeleton of a dog inside a metallic case that was found somewhere in the woods. And you can look inside also such things without opening it. You can document the situation without opening the case and already identify it's an animal cadaver inside there. And with that in mind, we wanted to try out how thick can the metal be to be penetrated and to see what's inside. And so we came to the idea, why we not scan such a traditional safe where we put animal bones inside, and also with such a safe you were able to look inside and visualize the bones with a standard clinical scanner. So it is quite impressive what you can do with a CT scanner, and you may develop ideas when you use it for postmortem imaging. Also in our institute, from time to time, the guys from the police, from the Forensic Institute come to us to perform a CT scan on an object so that they have a documentation of their object before they open the object, before they saw it open, or before they manipulate it. So for that, it can also be beneficial. When we start our CT scan, first of all, there's a scout view that's just a radiograph. With that view, just the table is moving, but not the X-ray. Gives an overview of the entire body, where you also can see metallic objects like here, the teeth implants is already visible on these topograms or pilot views. But with these illustration, you be quite correct with when you do perform length measurements from head to toe, but not from left to right, because you have diverging fan beam, and so it depends on the table height how accurate your depiction is from left to right. So do not do any measurements on the topogram except from head to toe, that you have the length, for example, if you want, but not any other measurements in other directions. They won't be correct. In our institute, we perform different CT scans depending on our protocol. Our standard protocol consists of 3 scans, or 2 to 3 scans. First of all, we perform a whole body scan from head to toe, here illustrated in orange. Then we perform a second scan over the head neck region, here illustrated in green. Out of that scan, we can do also do a reconstruction with a smaller field of view for the laryngeal structures in cases, not only in cases of hanging, but as a standard to diagnose the larynx as well. But more about that later. And the third thing would be either with elevated arms or when it's not possible, the arms next to the body, a reconstruction of the thorax abdomen region. Here illustrated in blue. If it's not possible to elevate the arms, we can reconstruct it out of the whole body scan. If we can elevate the arm, we perform a separate scan. And then we have also 2 standard additional high-resolution scans with the B-tube, where we can reconstruct 0.4 millimeter slice thickness. We perform their scans of the dental region in cases of identification, or also over the larynx region if we have already from the outside an indication that there was some trauma against the neck. Then we perform this separate scan with the higher resolution. Now I will show you a few important parameters for your reconstruction that can really help you in postmortem images. You may not be that familiar from clinical CT scanning because usually you may not perform, for example, a whole body CT scan where you also have the arms next to the body. But that's what we do in postmortem imaging. And there is something that can help you for a better visualization. It's the extended field of view. So usually scanner system, also from different vendors, allow to reconstruct beyond the standard field of view with a very good quality, because usually your detector element is larger than that. And so you can also include parts beyond that region inside your reconstruction field of view, and so get also information like here from the extremities, here from the arms. But the quality is not that good beyond the standard reconstruction field of view. So for example, here you miss the bony structure of the elbows. So with that, this I want to show it's always good to include as much as you can inside your standard field of view. You may use belts to squeeze the arms a little bit to the body for the reconstruction later, but it's not always possible. And if body parts are beyond that standard field of view, you may use an extended field of view. Of course, you have these parts with less quality, but you can have still some information on these regions beyond the standard field of view as well. And so this can really help. Here's another illustration that will show you what's a good idea to include also the extremities into your standard field of view. Here we use pillows underneath the elbows compared to performing a CT scan without pillows under that. So when you use pillows and squeeze the arms a little bit to the body, you may put it at the position where there's the largest diameter of your reconstruction. So you can also include that in your the elbows into your reconstruction. So positioning is an important thing later for the reconstruction as well. And yeah, the thing with the elevated arms, if you're able to elevate the arms, you will reduce artifacts inside the image from the bones here of the upper arms from left to right. You have these dark streaks. If you elevate the arms, you get rid of these streaks. But of course, it's always a debate if you should really put the arms over the head. You will increase, you may increase fractures. If it's older people, you will definitely cause hemorrhages into the muscle. And so you will create post-mortem findings you probably do not want to have in critical cases. So you really have to think of that as well if you want to perform post-mortem CT scanning and doing autopsy afterwards. So now if we have all our data, we use also as storage for this data. Usually in radiology, there's a PACS system where you can put all your reconstructed images, because in CT scanning, you usually do not store the raw data. They would be too huge, and without the raw data, you're not able to do all the different reconstructions anymore. So you have to think first which reconstructions you want to do, because also with our system, I think after 1 week, we erase all the raw data that we have space again on our platform for new CT scans. And of course, it depends how much scans you perform, because with this whole body scans and doing these reconstructions, you have a lot of images, and everything needs space on your CT platform. Also, the raw data is huge with this whole body scans. So think of what you want to reconstruct, and I give you some advice on that, or show you how we do it. At the end, you also want to have your images with the best, or the desired contrast you want to have with a good spatial resolution and also a high signal to noise ratio. And therefore are these different parameters important. First of all, here, the window setting, there is a preset you have to select, but of course, windowing you can later on. It's just a change of the histogram of your image to illustrate more the soft tissue region or more the bones, or even there's a special window also for the lungs. You can change that afterwards. Do not confuse that with the reconstruction kernel. Yeah, here's something that illustrates windowing a little bit, windowing, how you can do it after you have done the reconstruction on a dedicated software where you, which you use for diagnosing. And you can see here a projectile inside the head, and it really depends on your window range and window center what is illustrated in your image. Is it just a projectile, as here in the red frame? Is it the projectile with the bones? As we would do for a standard bone reconstruction, or is it with a lot of streaks artifacts, but with the soft tissue also illustrated a little bit in the image? It really depends on your windowing afterwards. And that is important, how you choose the window, because when you later present an image in court, people may not be aware of how you can also remove things from an image depending on the windowing you use. And this is something that you can, that is important for 2D images or cross sectional slices like here, and also for 3D volume renderings, for 3D visualizations. You can hide things with windowing. But you can also visualize things using the correct window, and also using an extension of your Hounsfield unit range. This is usually, in former times, it was something that was used in radiotherapy for CT planning. It's called extended CT scale. It just extends your standard Hounsfield unit range by a factor of 10. That is something we use very often for dental structure and also for projectiles in the body. At the end, for everything that is a metallic object and we want to visualize or be able to visualize with more clearly later on. Today, a more modern CT scanner will have the opportunity to do a 16-bit reconstruction, and there you already have also a larger Hounsfield unit range. Of course, it will be a larger image data, but in cases where you have metal inside the body, it can be really beneficial. Like here, we have a projectile that we have scanned on the left with the standard reconstruction, on the right, where we can window in a very high range, and by that also see the inside of the projectile. This is an Action 4 bullet with a plastic tip. It's designed for a very small mushroom, like you can see here in the small images, that it to avoid over penetration when firing on someone, and also creating some damage. This is a standard Swiss police ammunition, and you can, with using the extended CT scale, illustrate characteristics of projectiles, which may help you also to identify them. Or in this case, you can see also the imprint of a coin inside the body. Someone swallowed coins in this case, and to really be able to identify what it is it just a button battery, or are these coins? You can use this extended CT scale. That will really help you for any metallic objects to illustrate, like here on the left versus to the right, with and without extended CT scale. Here for dental implants, for the comparison with antemortem images, it can really help. Then we have the reconstruction filter. There are a lot of reconstruction filters available on your platform. You may have to decide which one works best for you. There are standard soft tissue and bone reconstruction kernel. For the lung window and lung reconstruction, we use the standard kernel that we also use for bones, but there are some others for laryngeal structures. Is a medium smooth kernel because of the cartilage structure. You may be more happy with such a reconstruction kernel, so you have to try it a little bit out depending on what you want to see on your images. And there are also some subjective preferences from the radiologist, how you want to have the image as well. For the reconstruction, slice thickness is an important thing in postmortem images. Often someone in clinical images is not so familiar with the idea behind it, because we perform always reconstructions with thin slices. Also for the visualization of soft tissue, like here in the brain, we do the reconstruction with 0.6 millimeter. We know that we have, with very small slice thickness, also a lot of noise in the images, but you'll be able to increase your slice thickness anytime afterwards with the standard radiological visualization software, and by that reducing the noise again. The important thing why we use 0.6 already in the beginning is because we do a lot of 3D reconstruction, volume renderings, and there is very important to have thin slices in all your reconstructions. You want to have a more or less isotropic voxels. And for that, you use small reconstruction slices. Okay, we increase it a little bit with the thorax abdomen range because it's going over a larger range, and also for the whole body scan, because otherwise it won't be that much images that your software may not be able to really work with it. And that can be something you have to keep in mind. But with, for example, for a head scan, no matter if we use a reconstruction for the bones or for the soft tissue, we use 0.6 millimeters. Yeah, the 3D data, that's the important thing with also the third dimension, 0.6 millimeter here with the slice thickness, and the other resolution is given by your field of view and your reconstruction matrix. So always for the reconstruction, adapt your field of view to the region you're interested in, like here for the head. And with your 3D data, you are able to do a lot of really advanced things in postmortem images, like here these curved multiplanar reconstructions and doing a multi-intensity projection as well. Out of that, like here for the comparison with antemortem dental scans, radiographs, you also can create such a panoramic view, and that can really help you in postmortem images or align your data set to a trajectory, of course, of a bullet that goes through the body. Here, once again, the important thing of having also a small slices that you avoid these steps in your image. In the volume rendering here, you can see it clearly, these artifacts you will have here with a small slice thickness where you do not have that in the reconstruction. And these you may also see if you use a very large field of view. It's not so good to see in that image, but there are also these circles you will see here. That is because of, in that case, the thick slices, and here a large reconstruction field of view with these steps in the images. Like you have larger pixels, voxels, in-plane voxels like pixels. So it's just then the third dimension is the slice thickness. And here an overview again of the parameters we adapt for postmortem CT scanning. What we want to see, depending on that, we use the kernel and the window, extended field of view for the whole body CT scan. Window is just a preset. Extended CT scale for metallic objects. It's just a box where I click yes or no. The same with extended field of view. Increment usually a little bit smaller, or at least the same like the slice thickness, that you avoid to have gaps between your reconstructed slices. I will just go briefly through postmortem angiography. I think that could also be interesting for you before I then switch to Michael Thali. You can do angiography post-mortem as well. Actually, they did it almost from the beginning, because angiography is nothing more than the depiction of your vessels. And at the beginning, they did it also when they filled vessels with wax. In the beginning, I mean the time when Leonardo da Vinci lived, and then maggots ate all the flesh around it, the muscle tissue, and at the end, what is left is just the beautiful vessel tree that was filled at that time with wax. There are also modern techniques where you can preserve the vessel tree like this. In postmortem imaging, it's a little bit different. It started, one of the first things they did was really they used diesel oil for an angiography of a dog. Of course, it's not what we want to show that often, this early study, because there are a lot of better things you can put inside a cadaver for visualization of the vessels. But yeah, at the beginning, they used this liquid to really highlight the vessels in the body. And I will show you now how we did it. We usually use standard iodine contrast medium, already outdated. We get them for free from the vendors, so they do not have to pay for disposal. They can give it to us. And we use a carrier substance that it stays inside the vessels and avoid extravasation. That is the polyethylene glycol. It's 200. It's a quite slippery liquid, but it works good to keep the contrast media mixture in the main vessels. Then we fill it up in a canister with this mixture 20:1. Shake it a little bit, not too much to avoid any bubbles inside there. Do a measurements, and we found out that it would be good to have a contrast media mixture that is between 300 and 400 Hounsfield units, that you are later able to differentiate it good from bones. And so it is advantageous to measure it first, although you have your mixture ratio, that you check this again. You always just scan the canister. Then you have to do an access for your contrast media. We usually do it for our angiography examinations at the femoral vessels, where we have these different equipment. First, make an incision inside the flesh, prepare all the muscles away from the vessels, and then there you do a tiny cut where you put in the cannulas. But before you do angiography, always take all your samples you need for later examinations. Here in the small image, you see these cannulas. These are inserted inside the vessel, and then these tourniquets are used to fix them inside there. And then we have this adapter that is put here on the cannulas, and a standard silicone tube we connect to the adapter as well. So that is the side on the body. Here's how it looks at the end. You can see the tourniquets to fix it, and the cannulas inside the vessels, one for the arterial, one for the venous access. And here, a 3D reconstruction after the angiography, where you also see the vessels. And here, again, the access. Of course, you cannot contrast the lower extremity on the side where you insert the cannulas, and also on the opposite side, you may have problems to fill it. But for the rest of the body, it works quite good. For filling it up, you can use a standard immersion pump, as we did later on. Also, we did a publication where we used the standard immersion pump to insert the contrast media. And former times, we also used the second-hand hard lung machine where we use the roller pumps. So it doesn't really depend what you use to fill in the contrast media. At least it should be a pump. Here, filling up the tube with the contrast media to avoid air inside the tube before you connect it to the body through the roller pump here. And if you've done that, connected, you're ready to fill in the contrast media. Early studies showed that it would be good to fill up the entire body up to the vessels inside the head with 1500 milliliter arterial and 1800 milliliter venous. Of course, it depends on the size of your body as well. And it's also not always that easy to fill up the head if you have your femoral access. There are differences depending on the body. Here's an illustration of the arterial injection, after the arterial injection, where the arteria is filled with the contrast media. And later on, we also filled in the venous system, the contrast media. You can see here both then on that image. And at the end, you can do these beautiful reconstructions here with the vessels illustrated with the contrast media, also in the head. And in that case, classical Stanford A dissection along the aorta you can visualize. But you can also visualize ruptures. Here, there's a lot of extravasation from a rupture in one of the vessels. You may perform continuously scans when you fill the body, not fill the entire body, and then perform a CT scan. It would be advantageous to see the steps when the extravasation is visible and do not have that much all around. So perform continuously CT scans when you fill the body with the contrast media. Also, other tiny things you can illustrate, like here, aortounal fistula, really impressive to show as well. And we also tried it out in decomposed body. It worked, but of course, you may cause a postmortem rupture in the vessels when you fill them up, and then it's in our case it worked for I think 20 cases we did in this study, but you have to keep in mind that it may also cause an post-mortem finding. And I think with that I have talked 15 minutes around that, and I think now it would be a good idea to switch to Michael Thali, that he can do his presentation, and that we may have at the end some time for questions. We will see. Okay, please, Michael Thali, take over.
Thank you so much, Doctor. If Dr. Dominic, if you like, we have some like 3 questions regarding your lecture. Is it possible to answer, or you want it all at the end?
No. We can also do it now as well.
Yeah. So basically, there's a question that says how to differentiate between postmortem thrombosis and antemortem causes, for example, in aorta.
Yeah, that's always a question with angiography. We also had once a case, we published this as case report where we thought we caused post-mortem something, a defect in while we filled the body up. It's also always the discussion with the clots. If it's contrast media, either the clots are pushed in the periphery or it's not filled where the clots are, and you have to be aware that there are clots and be not confused with the finding. So to be honest, I wanted to show you angiography because it is often presented and it works, but also in our institute, we do not perform it that often. It's not, one reason would also be that we have an MRI scanner, of course, but it's not non-invasive. You may cause findings, and it may be confusing to differentiate between things that are already there post-mortem and if it's not quite filled at this region, if it is really a finding or a normal post-mortem thing.
I mean, is the contrast, doctor, for post-mortem CTA differentiate? Like, for example, in antemortem, I think the contrast won't go around, but post-mortem, there will be a gap. So I believe...
Yeah, you just fill it up, the vessels post-mortem. There's not like in clinical radiology where the contrast media moves through the body. It's just the filling of the vessels. It depends on how much blood is left there and how the clots are left there. Also, calcification plays a role, how good you can fill your vessels and then illustrate the vessels. You will be able to really highlight aortic dissection, like in this case, and you will also be able to find small ruptures in the vessels where you can see there's an extravasation. That will really work.
Excellent, doctor. We have another question by Dr. Hamdi. He's saying that in cases of suspected malignancies, if it's possible to obtain biopsy guided.
Of course, we did. We had the advantage that we have a robotic arm where we can do biopsies. We showed that also in former times in publications. You can also do it by hand. With CT imaging, it's quite advantageous. You can do image-guided biopsies, to take image-guided biopsies, to put your needle really there where you want to have it, like you do also in clinical radiology as well, but you do not have the time pressure and things like that post-mortem. So if you want to have information from a dedicated region, you can do biopsies. We usually do it not that often because most of the cases we perform later on also an autopsy. But if you really do not do an autopsy later on, taking biopsies would be of course possible with CT scanning, and you really can also document from where you have taken your biopsies, that you are sure you are at the region where you took it, where your needle is. Document always where the needle is before you do the biopsy itself, before you're taking out the sample.
Thank you so much, Mr. Dominic. We can go with Professor Thali. The mic is yours.
Okay, thank you very much. Thank you, Dominic, for this excellent presentation. As Dominic mentioned, we are normally in daily practice, we are doing postmortem CT. So that's the main technique we are using in addition to that surface scanning. I think these are the topics of daily work and in the future. So postmortem angiography, that's nice. We did that for many years, but as Dominic Gascho told you, during daily time or in daily service, we are nearly never use it postmortem angiography anymore, and biopsy was nice. We did that with the robotic arm, the so-called Vertabot, but in daily use, then we often go direct for classical invasive autopsy. So after the introduction by Dominic showing you how we scan the body, double bag system, and some specific issues concerning postmortem scanning, I will give you a short overview what are the normal findings in postmortem CT scanning. So we have an hour, nearly an hour, and I will show you the topics. When we had some years ago, we had an extended rotation ship program between the Forensic Institute and the radiological department. And always when a radiologist came to our institution, they had some pitfalls by reading the images and the interpretation of the images. Okay, so I try. Oh, now it's not working at the moment. I try. Oh, before it was running. Sorry, I have to try it again. I do it again before it was working. Okay, give me a second. Okay. Ah, now it's working. Okay. So as you know, CT becomes in the forensic world the examination tool. So we will meet next week in Sofia, where the International Academy Forensic Science meeting is, a huge meeting, expected 1,500 people. And in this huge meeting, there will be the meeting of the International Society for Forensic Radiology in imaging. So if you have time, so that will be next week the place to be. There are all the people globally who are interested in forensic imaging, and there will be scientific communications, and in addition to that, some workshops. And so CT becomes in forensic pathology, I think, the technique globally. 25 years ago, that was totally different, but nowadays it's a really integrative technique integrated in the forensic pathology workflow. And so I will give you an overview. So postmortem CT fundamentals, then some organ system pitfalls you discussed already concerning postmortem findings like thrombus and all that. Then you have specific artifacts, and at the end some workflow and the medical legal implication which are necessary if you wanted to start as a radiologist in forensic pathology or forensic medicine in general. And as I mentioned during the first workshop, online workshop, it's always the collaboration. Learn what you can do in radiology and what you remember the sentence, what are the forensic questions you have to answer. And some of the forensic questions you can answer by using postmortem CT scanning, and sometimes you have even to do nowadays a real invasive autopsy. So maybe the typical misinterpretation, so that's an overview. So it's the lungs, so the interpretation, the postmortem interpretation of the lungs, that's very, very difficult. Then you have gas collection, air collections in the body. If you have that in a clinical setup, it's dangerous. You have some gas or air collection in postmortem CT scanning, which are absolutely normal. And then you have some specific findings in the skull brain area, which are very, very specific for postmortem findings and could be misinterpreted if you are only working in clinical radiology. So maybe the lung is really a problem, the gas is a problem, and some findings in the brain are special concerning to clinical radiology. So this is an overview. We will go in that in detail. I will give you some examples from our institution. So the hypostatic pulmonary consolidation are often or always misinterpreted by radiologists coming from a clinical setup as pneumonia. So that's the running joke in our institute. If there's coming a new radiologist, he or she is always saying, okay, if you have some background density in the lungs, they misinterpret that as a pneumonia. Then you have the gas. The gas is often putrefaction gas. So during the decomposition of a body, the gas develops in the body, in the soft tissue and in the organs. And that happens in the liver area. And a topic you already discussed is the blood sedimentation. Some people are thinking, okay, that's a thrombus, but some of the findings are absolutely normal in the postmortem setup. And then cardiopulmonary resuscitation delivers or result in rib fractures. And often people say, okay, this is just a traumatic injury. So it's always necessary that you know the story of the dead body. And then the cortical density in the brain, we will come to that. I will show you some pictures, is often misinterpreted as an encephalopathy or something like that. So these are the pitfalls with the red title and then the green title on the right side. Here, it's always, you have to know the story of the body. You have to know what is the postmortem interval, the PMI, and what are the position, condition and effects of the body. I will show you an example of that. And the gas, as I mentioned before, is dependent of the postmortem interval, and it's dependent on the decomposition time and all that. And you always, if you see a body, it's like in a clinical setup, you have to know a little bit of the history. That's similar if you scan a living body in the clinical setup, you often get or you need some information from the clinician, doctor, give you the information what's all about. And that's absolutely similar in postmortem scanning. So here you see a brain, and so some difficult findings or pitfalls in the brain is the hypodensity, which mimics pseudoedema, which is coming from autolysis. I will show you some picture. Then the loss of a gray-white differentiation, that's a normal finding and is not correlated to the clinical hypoxia injury. For sure, if a person is dead, you have the maximum of hypoxic injury, that's for sure. And then the blood pooling in dural sinuses, you have a blood pooling everywhere in the body, but you have that in special in the sinuses. And then if you have in some areas subdural hygromas mimicking, but this is a redistribution of the fluid around the brain. So these are some problems or pitfalls you have to know when you want to interpret or reading postmortem CT scan. So antemortem, this looks more or less normal, these findings, but postmortem, you see, so these are some autopsy pictures. I have some of them. I hope they are not shocking you too much. But you see here the differentiation between the gray and white area. It's you can even not see it, but this is a normal finding after death. So you cannot make the differentiation, but this finding is absolutely normal if a person dies over some times. Then this is a normal finding, and it's not a hypoxic disease or something like that. And then you have here another finding. So you see at the left side, antemortem scan, and at the right side, you see a postmortem scan. And look at the sinus here at the back of the brain. You see that here. I tried to move it, sorry. It's not moving anymore. Sorry. Now it's coming. You see here, you can see this at the back here that looks like a thrombosis, but this is a collection of the blood or the pooling of the blood, which is an absolutely normal finding post-mortem. So it's not a sinus venous thrombosis, that's a normal post-mortem pooling. And you have to know these effects, otherwise you are doing a misinterpretation of the findings. So here is an overview concerning the brain, in the brain area. You see the left side, hypodensity, subdural collection, sinus hypodensity, sulcal effacement, and pneumocephalus. On the left side, the true pathology in a clinical setup. On the right side, hypodensity is in a clinical setup, it's ischemic infarction. And if you have subdural collection, you have an acute subdural hematoma. And so the, the findings of the left side, you have the pathology in the right side, this is normal. Sorry, I was talking too fast. But the normal findings, post-mortem, you have hypolysis, you have the blood pooling and autolytic swelling. So this is an overview showing you the findings on the left side and the interpretation on the right side in a clinical setup. But in the middle, you see these are normal findings post-mortem in the post-mortem CT. And this is very, very important by reading the images. And so I brought you another picture. I got that from Dominic. Sorry. And you see here, what do you think is that? Normally you cannot see that in a clinical setup. This is a frozen brain. So if here in Switzerland we have snow here during winter time, so bodies are frozen in the snow, and when they are coming to the institution, we warm them up, and then you can see in the center of the brain, it's still frozen, the brain. So this is a finding I think you normally not see in a clinical setup. And here another thermal phenomena. You see that here it looks like where you can see the red star. It looks like epidural hematoma, but this is a special finding, a thermal finding. It's a finding if you have it's called an epidural heat hematoma. If you have charred bodies or a body is in the fire, then you have the effect. So it becomes very hot, and then the blood coagulates, and then you have this so-called epidural heat hematoma. So we have that if there's a fire, airplane crash or something like that, then this is a classical finding, and it's not a classical epidural hematoma. It's based on the fire influence to the skull and the brain or the head. So this is a pitfall. Often, if you do not know these phenomena, you misinterpret that to a vital during lifetime epidural hematoma, and that would be wrong in the interpretation. And here another one, a smaller one, it's the same effect. You see that it looks like epidural hematoma, but it's the effect is by fire, and so it's a classical epidural heat hematoma, and so that was the finding during the autopsy. So that's a really important finding that you should not misinterpret it as a vital epidural hematoma. And what is very, very important, these are the inner levorus. So if a person dies, the blood is going down based on the gravity. And you see that you have a blood pooling in the tissue, in the organs, and everywhere. And so what is very important, you have this blood pooling, especially in the lung area. You see here that in the cross section of the lungs, and this is often misinterpreted as pneumonia. But this is based on a classical inner levorus in the CT scanning. So this is an absolutely normal finding and should not misinterpreted. And you have all this blood pooling based on gravity after a person dies. Normally this starts after minutes and develops over hours. So finally you have this inner levorus based on gravity in everywhere in the body. So that means in the soft tissue, you have that in the vessel system, you have that in the heart, you have that in the lungs, in all other organs, and in the soft tissue. So that's very, very important to know, and these are the most misinterpretation done by classical clinical radiologists. So, and these sedimentation based on the gravity and the inner levorus, then you have this hyperdensity in the heart. You have sometimes it looks like a pseudothrombus in the vessel system, and sometimes you have even in the heart area so-called pericardial fluid. But this is often based only on inner levorus based on gravity. And again, you have a blood sedimentation, and often based on this effect, in combination with hypovolemia, you have a vascular collapse of the vessel system, and then, as I mentioned before, you have this cardiac sedimentation, and the blood looks then like you have different layers in the blood or cardiac chambers and in the vessel system. So here I have brought you a picture. You see here the blood sedimentation based on gravity. When you look here at the vessel system, you see here the different levels of the blood cells, and you see it. You see here a sketch at the right side. You have the red blood cells at the bottom, and then you have the plasma. So this sedimentation is absolutely normal, a normal postmortem finding. And sometimes you have the impression of this postmortem clotting. This, you discussed that before in the presentation of Dominic Gascho. You have this postmortem clotting, and sometimes you have the impression, okay, this is maybe a vital clotting, this is a thrombosis and all that. And Dominic told you we are doing postmortem angiography, but to be honest, it's never easy to make the decision or conclusion whether it's a vital thrombus or it's postmortem clotting, even if you are using postmortem angiography. So that's a classical finding you can see in the postmortem CT, and then in the autopsy it looks like that. So this is a classical postmortem clotting. It looks like that. You see, you have, as I showed you before, you have this classical sedimentation at the bottom, the red blood cells, and the plasma on the top. But again, this is a normal postmortem finding. So the hypostasis and the livor mortis on CT is, as I mentioned before, it's based on gravity, and the gravity effect, or this livor mortis, you can see in the soft tissue, in the organs, especially in the lungs, in the vessel system. And it's the CT correlation of livor mortis. Normally you can see at the skin from the outside this kind of livor mortis, but you have the same effect in the CT, and you can see the livor mortis even during the autopsy, but in the CT, in my impression, you can see them, the livor mortis, even better. So here, that's the classical livor mortis inside, and here a lot of clinical radiologists say normally if they come as a resident to our institute, okay, that's pneumonia in the back of the lungs, but this is a classical inner livorus finding if the person lies in a supine position after death. And here again, this is a classical livorus finding. And so here another picture. Now look at the picture and then you see, okay, we see this special effect, or it's the lung looks not perfect on the left side. And what is the finding, or what is the story behind? We can turn that a little bit. And I mentioned, or I told you at the beginning, always you have always to know the story of the dead body, the position in which the body was found. And so here, this is a body which was found lying on the left side on the couch, dead. And so you have the inner livorus based on the gravity on the left side of the body or the lungs. So this is again a normal finding, but you have to know what's behind, and it's always important, like in a clinical setup, that you get the information, the history of the patient in a clinical setup or the dead body in forensic environment. You have to get the information of the crime scene or accident scene, or the information where the incident happened and in which condition and how was the body found. So to be honest, the interpretation, the reading of the lungs, that's even doing that for more than 25 years together with excellent radiologists, the reading of the postmortem lungs or the interpretation of the postmortem patterns of the lung, that's very, very difficult. You have this consolidation, you have sometimes aspiration of stomach content, sometimes aspiration in drowning cases of water. Then you have this pleural effusion. You have after the cardiopulmonary resuscitation, you have some findings. You have ante-mortem aspiration. And so again, the interpretation of or reading the lungs, that's very, very challenging. I think that's the most difficult organ we have. That was the reason we started many years ago, like postmortem angiography, like a postmortem biopsy. We had a project of postmortem ventilation of the lungs. So that was an academic project. We are not doing that in a daily practice nowadays, but the lungs, the lungs or the organ of the lung, this is the most difficult in postmortem reading and interpretation. And so what is special, and you do not have, I hope, in a clinical setup, this is the decomposition. So after the livorus mortis, and so the first, after that, they are coming the livorus mortis, and then the rigor mortis. Rigor mortis you cannot see on the CT scanning, but then there are coming the effect of the decomposition, the putrefaction. And so you can see these effects in the CT scan. Mainly you can see that by the development of gas inside the body, in the soft tissue, in the organs, everywhere. And then you have so-called putrefaction artifacts. These are the normal postmortem development, starting maybe after, depending of the environment, the temperature, normally starting in Switzerland after 2 or 3 days. If you are in Saudi, I think that will start even earlier, and then the putrefaction a little bit later. And beside these normal effects, you have often traumatic pathology overlaying, and then you have to make the differentiation whether this is a real traumatic evidence, a vital thing, or it was done by the residue work, cardiopulmonary resuscitation and all that. So we are going in that topics, the normal decomposition and putrefaction process. So here again an overview. I already mentioned that to you. You have the early changes, postmortem changes. This is the hypostasis, livor mortis. Then you have this already mentioned vascular and organ blood pooling, and then you have sometimes gastric reflux. And later you have this putrefaction gas. So gas is a very, very important thing. And then you have even organ liquefaction. So everything becomes fluid. So that's not very nice during the autopsy, the classical autopsy, but in the CT or radiological approach, that's much more elegant. You can see that on the cross-section imagings. And then you have, if it goes longer, you have in the dry area, you have mummification and adipocere. That's a development if a body is under the water for a long time without oxygen. You have this so-called adipocere development. And so again, the changes of the dead body, you have the normal findings around some hours after death, but if it takes more, 1 day or even more than a week, then you have additional developments, normal developments in the postmortem setting. Okay. So I mentioned you, and I will show you some picture. That's an overview, the gas distribution. In forensic, the forensic doctor know that it's always the question, is it vital gas embolism? So vital gas embolism is the indicator that the person was alive when the vital gas embolism developed. So vital gas embolism develops if there's a vessel system open during lifetime, and then the gas is sucked by the vessel system, and the gas is delivered during the person is still alive in the body. And so if you have this vital gas embolus, that's a vital sign, that's very important for the forensic conclusion. Then you can say, okay, the person was during the accident or the impact to the body was alive because of the vital gas embolism. Now the problem starts having all these putrefaction effects. So the development of decomposition, you have this gas, the decomposition gas in the body. And sometimes it's not so easy to make the differentiation between the vital gas embolism and the gas by the postmortem development based on the putrefaction. So this is an overview concerning the correlation, distribution, location, the correlation with postmortem interval, where you can see it in the heart area and the clinical context. To be honest, it's like the thrombotic interpretation, the blood thrombus interpretation. it's not always so easy. Sometimes if you have a real putrification or a decomposed body, a fully decomposed body, for sure, then it's easy. But if you have only a little bit, little gas bubbles in the body, then sometimes it's not easy to do or to make the right interpretation or the right forensic interpretation. Okay, so some artifacts, again, gastric reflux, I already mentioned that, and then you have the gas in the portal venous system, and then the putrifative gas, you have the same effect inside the bowel, and the bowel having all the gas based on the bacteria, the bowel grows, and then you have the you have the feeling or you have the impression that there's something wrong in the bowel system, but that's a normal development post-mortem effect based on the decomposition. And the same you have based on the decomposition, you could have free fluid in the pleura or peritoneum. So these are some findings you have to know. This is absolutely normal, and these are really the so-called postmortem pitfalls in reading CT scan. So again, an overview. Going back, putrifative gas is really based on bacterial decomposition inside the body and in the soft tissue, inside organ, and this is again a normal postmortem finding. And you have to make the differentiation to the vital air embolism. And this vital air embolism again is forensically very, very important, because based on a vital air or gas embolism, you can say, okay, the person was alive when the incident, let's take a traffic accident. So a pedestrian is crossing the street and then hit by the car. The vessel system is injured, and then you have gas is going inside the body, and then that's evidence or proof that the person was still alive during the incident or when the pedestrian was hit by the car. And again, you could have, beside the bacterial decomposition, maybe you have an infection before, and then if you have a clinical infection, for sure, you could have gas in the body. And so you see, it's very, very difficult. You can have gas or air based on an impact to the living body. You can have an infection, and then you have gas somewhere in some organs, and then you could have gas based on the decomposition process. So again, this is forensically very, very relevant, because at the end, that's evidence of our evidential finding for the court system and the police. And so a misinterpretation would be maybe critical for the case. So you see here, if you see that in an antemortem case, then you would say in a clinical setup, okay, that's a pneumatosis intestinalis, and this is yes, this is a clinical problem, this intrahepatic gas. But if you see something like that, that could be in a postmortem setting with starting decomposition, that could be an absolutely normal finding. So that's a really normal postmortem finding. And so again, you have to know the background of the postmortem development, again, livorus, and the development of postmortem gas in the organs. And here, another finding, you see that here, postmortem finding, I'm going back. So that looks normal. You see some gas in the in the skull or around the brain. And then here you see even more, so the decomposition process is developing more and more. And here you see even in the frontal part of the skull, you see a lot of gas based on decomposition. And again, that's a totally normal finding in postmortem CT scanning, maybe after, here in Switzerland, after maybe a person is 1 week or 2 weeks dead. Then you have in a specific environment, you have such a brain decomposition like shown here in the CT cross-section postmortem imaging. And here, sorry for the shocking picture, that's the correlation with the autopsy finding. And you see, I personally prefer more the CT picture. It looks more academic, and there is not a real smell like you have in the autopsy room. Again, if you have besides the air effect, so based on the decomposition, the organs or the tissue becomes fluid. And you see that here you have, it becomes more and more fluid. You cannot see structure inside, but when you are looking very close to the brain system here on the left side, then you have the impression beside the liquefied fat of the brain, you have a subarachnoidal hemorrhage, and you could see that here a little bit even better in the autopsy finding. You see here it's the subarachnoidal hemorrhage in that. But again, as I mentioned before, the interpretation postmortem of lung, that's very, very difficult, and sometimes the interpretation of a brain findings is not so easy. And then here, other picture, you see here some postmortem changes, some collection of decomposite fluid in the pleural area, in the lung structure area, even in the soft tissue area and in the abdominal area. And again, these are normal findings if you have, or if a body is dead for 1 or 2 weeks, then you can see or find these morphological pattern, which are absolutely normal in the postmortem setup. If you see similar images in a clinical setup, I think the interpretation is totally different. And then another finding, sometimes you have findings that you see the bone structure or the alignement of the vertebrae are not so correct. And Dominic Gascho told you that before. If you are transporting the body, or you are elevating the arms, or if there's happening during the transport from the crime scene, incident scene of the body to the institute, it could happen something to the body. And here you see that if you have a decomposed body or even a mummified body, when the head is moved from the vertebra, then you see this finding. And maybe sometimes that's based or the basic of this misalignment of the vertebrae to the head is based on the transportation. And so again, you should know what is the history of the body, what happens to the body, what was the environment where the police found the body, how was the transportation, and so on. And here again, mummification effect, you have then again here in the brain area, you have the gas, and you see here on the right side the 3D reconstruction of a mummy or mummification of a body. And then because of the dehydration, you have, for example, bulbar shrinkage and a dislocation of the structures of the areas of the eye. You can see that here. And so again, for sure, if you have a mummy or a decomposed body on the CT scan, you know that. Maybe you can even smell that through the double bag system, but the findings are again totally, absolutely normal. But you have to know the decomposition or the signs, what will happen or what will be the impact or influence to the CT findings. And here, other pictures, decomposition, and you can see that here, these findings, the frontal view and the cross section, and you see here decomposition of the organs. You see the structure, the liver, and all that looks different. Then you have in the middle soft tissue emphysema based on the decomposition, and you have the gas embolism on the right side. And it's always you have to do the interpretation. Is it the decomposition on the left side, which is post-mortem, and maybe you have soft tissue emphysema based on a traumatic incident in the middle after an accident or something like that, and then gas embolism. And it's always not always so easy. And again, you have to know, like in a clinical setup, if you have to read the pictures, the CTs of a living patient, you have to know what's all about, what is the story of the patient or the dead body. And here another pictures you see if you have blood loss or you have exsanation or exsicosis, the aorta or the vessel, the volume becomes smaller and smaller. I'm going back here, becomes smaller, and then you see, okay, you have not so much volume in the heart or vessel system, and this is an indication for exsanguination, so the blood loss or the exsicosis of a dead body. And here another sign. Then we, in our first publication, now 23 years ago, so autopsy, new approach or new horizon in forensic pathology and so on. We mentioned the first time the collapse aorta as a sign of exsanation, blood loss, or exsicosis, and then based on that you have a hyperattended aortic wall, and this again is an absolutely normal finding, and you have to know the story of the dead body, what happens to the body, and so on. That's very, very important. Okay, you see that here. Okay, the collapsed aorta, ascending aorta, which is really a normal finding. Okay, and then other topics is really in the bone and soft tissue. There are some pitfalls too. So starting with fractures, if you have the composition gas in the bone marrow, that could mimic fracture lines, but this is a normal finding. We have talk about soft tissue gas, which mimics traumatic emphysema. We saw that before. And then desiccation artifacts, if the skin becomes very, very dry, and so, or even in the influence of heat or something like that, then you could have a laceration or skin retraction, and then you have the impression, oh, that could be incised wounds or something like that. And so that's very, very difficult. And again, you have to know the story of the patient or the dead person, and it's always you have to get some basic information as a radiologist from the forensic pathologist or for the police. If you only scan the body without information, I think then it will not become a success story. Okay, here some findings. You see here some fractures, and then indicating with the gas, you see there here that some fracture, sternum fracture, and then here a rib fracture in this area. And always you have to ask whether there is a cardiopulmonary desiccation made, which mimics some traumatic findings during the person or when the body was still alive. And then we are doing, as you are doing in the clinical setup, these 3D reconstructions. We are very, very collaborative or strong link to Siemens because they have excellent software, excellent scanners, and then doing this cinematic rendering that looks very great and good, because at the end you have to represent the results, the findings of the radiological interpretation to the police, to the court system, or to the forensic pathologist, and then it's necessary to have an excellent 3D visualization that the medical layman can understand the findings you found in the CT scanning. And then here, resuscitation, also here you see the gas in the stomach area. And then you have to know what happens to the person after she was found, maybe still alive a little bit, and then doing this cardiopulmonary desiccation, arriving in the emergency room in the hospital, and what are the effects by the clinical setup, and not maybe to the forensic incident or accident which happens before. And Dominic Gascho told you that you have a better image quality if you are elevating the arms. So when we started, we did that every time, but then you have to open the double bag system. And if you are scanning in a clinical setup, so people around there normally do not like when you are opening the double bag system, but elevating the arms, that's always gives you a better quality. But then you have sometimes, not often, postmortem fractures and luxation, as you can see here in the images. So here a summary. I know this presentation is recorded, so when you go back, that's a summary. The effects of resuscitation. You could have rib fractures, you could have pneumothoraxes and sternal fractures, and sometimes you have mediastinal air, and this is again mimicking some effects, and you have to say, okay, if there an accident happens outside there and you have some emergency medical interventions when the patient arrives still alive at the hospital, you have to make the differentiation what is done in the hospital to save the life of the patient and what was the effect outside. Sometimes it's overlapping the effects, but again, you have to know the story of the patient. So that's a little bit a workflow. You see some findings in the postmortem scan. Then the next step is it maybe gravity dependent? That means, is it innerlivorous based on gravity? Is it decomposition? And then you can say, okay, when it's okay, you can go to the final forensic radiological conclusion. And if it's not consistent, then you have to ask whether the postmortem interval is consistent. And then, for example, in the gas, you can say, okay, it's okay. And if it's not okay, then you have to ask, maybe there are other effects from the scene. Maybe there are some special conditions at the scene. Then you have to ask maybe whether the body was found in the water. Then you have other finding in the lungs. Maybe the body is found in the snow. Then you have maybe a frozen brain again, or the body is coming from a fire area. And so it's always a little bit it's the gravity, it's the postmortem interval, and it's the clinical or scene context. I think that's similar to a clinical interpretation of radiological scans, but the topics are a little bit different because you have to know sometimes is the scene context very special in the forensic world. Okay. Again, this is an overview. You see what you should do. So I told you that several times. You have to interpret the postmortem findings in a full forensic context, only to read the images and to make a good diagnosis. That's not possible, but I think that's not possible even in a clinical setup. And what is important, if you are reporting an wrong diagnosis, which may be with the lack of information to the crime scene or the circumstances, your diagnosis or your report goes in the criminal investigation, and if your reporting is wrong, maybe the whole criminal investigation goes in the wrong direction. So it's very important. You know, medical malpractice in radiology, that's a topic forensic radiology, forensic doctors have to interpret it sometimes, but it's really, you can do wrong diagnosis in forensic, and this you should avoid. And if you are not sure concerning your findings, then you can say, okay, I'm not sure, it's not certain, it's probable, and possible findings. Because you see that on the right side, it's really a red flag if you are not totally familiar with the postmortem findings and you are reading postmortem CT scans and give a report or diagnosis which is not correct. And that's again, that's a collaboration between the two fields is very important, and maybe some promotion for our autopsy course. I think we try to give that information during the 10 days people normally spend time in Zurich, or maybe we can do in the future a mini autopsy course in your area. You know that slide I showed you that at the beginning, again, like a summary, the pulmonary finding or interpretation of the lungs, very difficult. Often misinterpretation is the inner levorus as a pneumonia on both sides of the lungs, in the back area of the lungs. Then we discuss the gas in the brain, in the liver, and in the soft tissue. So it's always differentiation to vital air or gas embolism. We discuss blood sedimentation. We discuss the cortical density in the brain, and then some traumatic findings based on CPR or even in the transportation of the dead body. You remember the disarticulation of the vertebra from the head, and then the elevation of the arms during the scan. And then we discussed that you have to know the story of the dead body, that you can correlate all the postmortem findings you found to the story, like in a clinical setup. So again, checklist, pneumonia, we discussed that, the gas, mesenteric gas, the CPR effects, and then the sinus pooling. I show you that with thrombosis, so that's a normal finding, and then all the gas based on putrefaction and decomposition. So I'm coming to the end. Key takeaways, so postmortem changes are the rule, not the exception. We discussed all the main topics of physical developments after that. And context is everything, like in a clinical setup, and then correlation. It's again make the bridge from forensic radiology to forensic medicine and pathology. If what you want to do in Saudi Arabia, start the project. Collaboration is very, very necessary. It's not only useful, it's absolutely necessary. And if you are not sure uh, of a finding, and then declare that. So uncertainty must be stated, otherwise you can really mess up a case, and a forensic case mess up. These cases are always going to media. So be careful. Uh, uh, Reading images, always collaboration with the forensic pathology, because working together becomes a success story. So I'm coming to the end. We are still in time. We have some time for questions, and I really hope to see you soon in Saudi Arabia for maybe an in-person workshop or during a forensic radiological conference. Thank you very much.
Thank you very much, Professor Thali. That was very informative lecture, and right on time. I have many questions, but I will try to make it short. So, since I am coming from the clinical part, and we have this new, relatively new service coming as a postmortem imaging.
Yeah.
I think the most cost effective, I think, is to start from hospitals doing these examinations. But the problem that we may face, or we already some of my colleagues faced, is the workflow is a bit difficult about registering a dead patient, who's the most responsible person for this examination, to whom we are writing the report. Is it for the forensic medicine or police, or who's taking care of this report? Because as you said, when we have so much uncertain findings, it has so much not clinical, it has legal complications later on.
Yeah.
So from your perspective, what is the ideal workflow coming before the exam until issuing the report and finalizing the report by the forensic medicine and taking the correct action? If you can just highlight one common scenario that you see in your practice, because as you said, history, background information, the story is always very important in radiology or anything related to radiology. And taking the image, if radiology is a story, taking the image is only one chapter. So if you can just highlight one example so we can learn from.
So that's, I think, one question, but that's like a book chapter or even a book yet. But I understand it very well, because I was in radiology for 2 years, and my wife is a radiologist. And so it's always only look at the pictures or only doing the autopsy, it's the same. You cannot solve the case. So you have to know the background information. So the best clinical radiologist is always the radiologist who had the best connection to the surgeons or the medical doctors to get the information what's all about in the patient. And that's similar in the forensic community. So scanning, when my understanding is correct, at the moment you are scanning dead bodies in a clinical setup. We started similar, I think, or I hope in the future you can do the scans in an institute in Saudi Arabia, like we are doing it here in Switzerland, in Zurich, Bern, and other university institutions. So the problem is a little bit, when we started, that's now 25 years ago, we started at the Insel Hospital in Bern. We scanned the dead body during nighttime, and we, as forensic pathologists, went to the clinical or to the hospital, and we gave all the information to the people who scanned the body. So we had always an excellent technician and a radiologist who gave us the first interpretation. So what at the end the interpretation is, that depends. So personally, you can write a very, very detailed report, but often that's not necessary. I showed you the last time during the first online course, maybe a pictorial overview of the mind finding, it's much better. And finally, I think for the final report, I think the forensic pathologist who knows the forensic question should write or give the final report. And as a radiologist, you should deliver the findings, the information. And if you have an excellent collaboration, you can even sign the final report together. But there are a lot of variations what you wanted to do. At the beginning, we only wanted to have some nice pictures from the radiologist, and we say the classical reporting, the final report, autopsy protocol with some pictorial views from the autopsy and the CT. So we started like that. Nowadays, as I mentioned you the last time, we have the final report with some nice, informative storytelling, often 3D reconstruction of the CT findings. But it's a long way. So at the beginning, I would start to scan in a hospital setup. If possible, an excellent technician should do the scans, and the forensic pathologist should be present during the scanning, and at the end, maybe a radiologist should come there and say, okay, look together at the pictures and give a first result. So this is the first step. And then it's always good collaboration. I know a lot of projects globally. If the forensic pathologist only send the bodies in the radiology department and get a written report, that never becomes a success story. It's always really collaboration together, forensic and radiology.
Perfect. Thank you so much. We just received this question. The question says that what is the role of emergency physician in your institute, if there is any, regarding this topic?
Sorry, can
The role of emergency physician, if there is any, for in this topic.
So we have not an emergency physician at our institute. What I learned, the best radiologists who are very close to the most closest to forensic medicine are often emergency radiologists. So we are often invited at the radiological meeting, RSNA or ECR, in the emergency radiology session. So there are closest. So a breast radiologist or mammography radiologist is often not so close to forensic, but emergency radiologists are very close to us.
Okay. So I think we don't have much questions. So since we have a little bit of time, I'll ask one question. You mentioned so many changes that are expected in the postmortem period. Let's say we scan a patient with no real history. We just found the patient dead. So the main reason of doing the exam is understanding why the death happened, or we just doing the exam and just fishing for anything, because it seems like most of the findings can mimic important diseases or deadly diseases, like necrotic bowel or brain hemorrhage or such.
Yeah. So what I wanted to show in this session, what are the normal findings? To be honest, when we started to scan dead bodies 25 years ago, we wanted to screen whether we can see main forensic relevant traumatic findings. So what you can see, excellent gunshot to the head or broken ribs and all that. And so what I showed you today was only the normal findings. So if you have a dead body without traumatic injury, without disease, without cancer, without stab wounds, without blunt force injury and all that. What I presented today was only normal findings like inner livorus, gas collection, decomposition. But if you are scanning a body totally fresh after 1 hour, you have maybe no decomposition gas, you have inner livorus effect, maybe you have only in the lung area, and the rest is more or less normal. But today, what I showed you was only the normal findings.
Okay, thank you so much. So I will leave the mic to my colleague, Dr. Abdelaziz, for the closing.
Thank you, Dr. Ryan. I mean, very excellent questions. And thank you, Dr. Thali and Mr. Dominic. I mean, yes, he raised a very important questions regarding postmortem intervals. I mean, the last session you gave us, Doctor, I mean, the last few lectures that, or layers that you showed is that how do we know if it's abnormal if we don't know the normal? So it's very important to know the normal so we can know. And postmortem interval is very important in our forensic settings, not just to identify the time of death, but also to know from a CT scan that this is considered as a pathology or not. And actually, it was very fruitful. Everybody's happy regarding this wonderful session. From this point, as we come to the end of today's webinar, I would like to extend my sincere thanks to our distinguished guests, Professor Michael Thali and Mr. Dominic Kochit, for sharing their valuable insights and expertise with us. It has truly been an enlightening and engaging sessions for both specialties, forensic medicine and also radiology. I would also like to express my appreciation to the Saudi Society of Forensic Medicine and the Radiological Society of Saudi Arabia for their contributing and continued support in making this webinar possible. A very marvelous webinar, actually, and for their dedication to advanced knowledge and collaboration in the medical field. To our audience, thank you so much for your active participation. Thank you to my host, Dr. Rayyan, and thank you everyone for engagement. It was, I mean, this is what makes the session meaningful and impactful. We hope that you found today's discussion informative and beneficial for your practice. We look forward to welcome you again, and we welcome you, Prof. Thali and Mr. Dominic, in Saudi one day, inshallah, to go further in this topic. Thank you all for joining us, and you have a wonderful day.
Thank you very much, and hope to see you in Saudi Arabia in the near future. Inshallah. Bye-bye.
Thank you so much, Doctor.